Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. We shall continue our ECG week. Remember, these are a series of lecture videos that are pretty much going to be teaching you what you need to know about ECG. So we're getting you from this and to you understanding exactly what is going on with the ECG and what you need to know as a student, what you need to know as a healthcare practitioner. So in our previous lecture, we introduced the different parts of the ECG. So I hope everyone actually understood that lecture very well, because this will now lay the foundation for the next lecture and of course the subsequent lecture. The interpretation of the ECG, we shall cover it in two parts. So in this lecture, I will give you the basic components of an ECG and what they represent, the normal findings on the ECG, and I'll mention a little bit about some pathologies. Then in part 3, that's where the serious stuff will begin. So I'll give you a step-by-step sequence of how exactly you should be interpreting an ECG from now on until the day you die. Maybe not the day you die, but until the day you retire as a medical practitioner. So remember that the heart is made up of muscle. The atria is made up of muscle. The ventricles are made up of muscle. And the muscle mass of the atrium is far much less than the muscle mass of the ventricle. So it means that when the atria contract, they're going to depolarize, and the contraction is very small. And the waveform that's going to be generated from the contraction of the atrium is referred to as the P wave. On the other hand, the ventricles are very large, and when these ventricles depolarize, they are going to result in a large depolarization, which is referred to as a QRS complex. Or you could call it a QRS interval. Some people call it an interval, some people refer to it as a complex. So it consists of a Q wave, which may not necessarily be there on all the leads on the ECG. If you do not know what leads are, I will leave a card at the end of the video to direct you back to the first video so that you understand what leads are. Then the R wave and the S wave completely form the QRS complex. Then the ventricles are eventually supposed to repolarize back to their resting electrical state. So the wave that is there is known as the T wave. Sometimes you may get an additional wave, especially if the heart rate is very slow enough, which is known as a U wave. Remember, on our ECG, we do not necessarily see atrial repolarization because you can think of it like it's hidden behind the QRS complex, quote unquote. So here's a very good example of an ECG. So you have a P wave over here, you have a Q wave, you have an R wave, you have an S wave, you have a T wave, sometimes you may have a U wave, okay? Then a P wave again. So it's not always that you see the U wave. You may see it sometimes, you may not see it. I shall give you the scenarios when you see the U wave. And of course, this is the isoelectric line. Then of course, this ECG is going to have intervals. It's going to have segments. So you have the PR interval, which is the beginning of the P wave to the beginning of the Q wave or the beginning of the R wave. It's known as either the PR interval, or you can call it the PQ interval. Then you also have a PR segment, which is at the end of the P wave and the beginning of the Q wave. You have a QRS interval, like I told you, which is consisting of the entire QRS complex. You have an ST segment, which is the end of the QRS complex to the beginning of the T wave. This should be at an isoelectric line, so it should neither be positive nor should it be negative. Then you have a QT interval, which is simply showing you ventricular activity. So from the start of the Q wave to the end of the T wave. Okay, so these are the basic components of the ECG. And remember that the ECG is going to be having small boxes and big boxes. Depending on the speed, remember I say that we should keep in mind that we're going to be using a speed of 25 millimeters per second. So each small box will represent 0.04 seconds. So it means that each large box is going to represent 0.2 seconds. And then moving upwards in the voltage, each small box will represent 0.1 millivolt. And then it means that two big boxes will be equal to 1 millivolt. So again, here is another depiction of the components of the ECG, just to hammer the point home. So you have waves, the P wave, the T wave, the U wave. You have intervals, the PR interval, the QRS complex or the QRS interval, the QT interval, and of course you have segments, this ST segment. These are the most significant components that you need to be wary of, or that you need to take note of on the ECG. Here's another diagram to even clearly emphasize these things. Now remember from our previous lecture, we say that the ECG has these 12 leads, which are pretty much views that you look at the heart. So you have lead 1, lead AVR, lead AVL, which are known as lateral limb leads. These are going to be looking at the lateral surface of the left ventricle. Then you have lead 2, lead 3, and lead AVF, which are pretty much looking at the inferior surface of the heart of the left ventricle. They are known as inferior limb leads. Then you have leads V1 and V2 looking at the right ventricles as well as the ventricular septum. You have V3 and V4 looking at the anterior wall of the left ventricle. Then you have V5 and V6 looking at the anterior walls and the lateral walls of the ventricle. Keep these principles in mind because these are very important, especially when you want to localize certain pathologies on the ECG and you want to localize them on the heart. So here's a graphical representation. Here you have a lead 1, lead 2, lead 3, lead AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So lead 1 and lead AVL is the high lateral leads, so the lateral aspect of the heart. Then you have V5 and V6, the lateral inferior aspect of the heart. Then you have the inferior aspect of the heart, which is lead 2, lead 3, lead AVF. You have the septal view, which is lead V1 and part of V2. Then you have the anterior view being part of V2, V3, and V4. So take some time to actually absorb this diagram in your mind and keep it in mind. And remember, here we can see that the waveforms that we see in the AVR are inverted, like I told you on the other. As you can see, we have this P wave here that appears inverted, and this is normal for an ECG reading. Okay, so here are the different depictions of the different ECG waveforms on the different leads. You have lead 1 over there, lead 2, lead 3, lead AVF, lead AVR, and lead AVL. These are limb leads. Then you have lead V1, V2, V3, V4, V5, and V6. So we shall discuss why each of these patterns appear like so on different leads very shortly. So remember that the electrical impulse in the heart is starting off from the SA node, like we already established, and then is going to be carried by these internodal tracts, the tract of Bachmann, the tract of Thoreau, and the tract of Wenkbach, such that the atria are going to depolarize as a syncytium, and then eventually blood is going to be pumped from the atria to the ventricles. And then this blood that is in the ventricles, the impulse rather, is going to reach the AV node and cause the AV node and the bundle branches, the left and right bundle branch, and eventually the Purkinje fibers to depolarize and cause contraction of the ventricles to push out the blood. But remember that the tissues of the heart, these conducting tissues of the heart, have a property of automaticity, meaning that they could generate their own action potential. So it means that the SA node can generate the action potential, the AV node can, and even other tissues along this conduction pathway, but they generate the action potential at different rates, such that if the AV node is no longer generating the action potential, the next best thing would generate the action potential. Like for example, if you have a president, then the president decides to step down for whatever reason, then the vice president will take over. Think of it like that. So the SA node, which is a predominant pacemaker, is going to be firing at a heart rate of 60 to 100 beats per minute because it fires the fastest, so it controls all the other tissues. Then the AV node is one of the backup pacemakers, which has an intrinsic rate of 40 to 60. So whenever you calculate the rate of the heart on your ECG and you find out that the rate is somewhere 40 to 60 and there's a delay, there's a blockage somewhere there, it means that this rhythm that you are getting is known as an escape rhythm, because these tissues have escaped the control of the SA node. Then you may sometimes have ventricular cells which are also backup pacemakers, and they have an intrinsic rate of about 20 to 40 beats per minute. So you could have a junctional escape rhythm, you could have a ventricular escape rhythm. Then remember also, we said sinus rhythm is an impulse that's starting off in the SA node, being carried along the internodal tract, being carried to the atrium, to the AV node, the bundle of His, the left and right bundle branches. Remember, the left bundle branch has an anterior and a posterior branch, and then of course the Purkinje fibers. And if it has the normal timings and the normal delays, you refer to that as your normal sinus rhythm. So now let's go into details of each of the waves, and I give you the basics and what is very common on each wave, what is considered normal on each wave and on each important segment. And then in the next lecture video, which is the most important video of these series, is learning now the systematic approach that you take in interpreting the ECG. So the P wave is the first wave. So this is going to be a small rounded wave. It may be positive or it may be negative. Okay, so the P wave is going to be upward in lead 1, lead 2, lead AVF, but it is inverted in lead AVR, like the diagram I showed you much earlier on. So the P wave in lead AVR is going to be inverted. Then sometimes in leads V1 you may get what is known as a biphasic P wave, which has both a positive and a negative component. But remember, the negative component of the P wave should not exceed 0.04 seconds in duration. So it should not be longer than one small box. So if it's longer than one small box, then that's abnormal. So the normal duration of the P wave is that it's roughly less than 3 small boxes. Okay, I find it much easier to remember the boxes than to remember these numbers over here. So let's focus on the boxes. It should be less than 3 small boxes. Then the amplitude of the P wave should be at least less than 2.5 small squares. So it should be less than 2.5 small squares. If it's greater than this, then those P waves are peaked. So the abnormalities that we'll look at when we go into details of different abnormalities of different ECGs, they could be bifid, a type of P waves, which I suppose you see in P mitral stenosis or P mitrale. You can have inverted P waves, you could have absent P waves. Sometimes the P waves could be peaked, and we shall link each of these pathologies to or each of these ECG findings to a specific pathology, such that if you see this on the ECG, then it could be, like for example, mitral stenosis, it could be pulmonary embolism. So as you can see, like I said, in the lead AVR, which is over here, you see that the P wave is inverted, and pretty much almost all the other waves are also inverted. Remember, the impulse is depolarizing away from AVR. That's why they appear inverted, while the P wave is positive in almost all the other leads. And also in lead V1, the P wave may appear biphasic, though this is very, very far from the screen, so I doubt that you can actually appreciate it much from here. Then the next thing that you have is the PR interval. Now, I wonder why you call it the PR interval when it comes from the P wave to the Q wave. That's because sometimes you may not have a Q wave. So you can refer to it as the PQ interval, but that sounds rather weird, so no one calls it that. So just refer to it as the PR interval. So this is just simply now that time which is the impulse is going to take from the SA node for it to reach the AV node and cause the AV node to depolarize and the ventricles to contract. So remember that there's a delay now in between stimulation of the AV node, because this gives time for the atria to contract and fill the ventricles with blood. So we measure this from the beginning of the P wave to the beginning of the QRS complex. So normally it should be 3 to 5 small boxes. So that's roughly 0.12 to 0.20 seconds. So 120 milliseconds to 200 milliseconds. So 3 to 5 small boxes. Like I said, it's much easier to remember the boxes than it is easier to remember these values over there. Now, the P wave could shorten or it could lengthen. If it shortens, there are 2 important possibilities that I want you to think about. So if it shortens, it could either be the impulse is being generated somewhere else in the atrium, other than the SN node, and this place could be very close to the AV node. And most of the times you find out that if this is the case and you have this ectopic focus, the P waves on those other leads will become inverted. Okay? Or the second problem could be you have an accessory branch that is directly bypassing the AV node and conducting this impulse much faster than the AV node. That's why you can get the shortening of the PR interval. Or it could lengthen, for example, in heart block, and there are different degrees of heart block that we'll look at: first degree, second degree, and third degree. Then moving on to the QRS complex, remember that this QRS complex is simply going to be representing ventricular depolarization. So the first deflection is usually a downward deflection, but it's not always that you have a downward deflection. Sometimes you may have a downward deflection in certain leads, sometimes you may not have a downward deflection. So if there is a downward deflection, you refer to that as a Q wave. So that's the Q wave, the first downward deflection. Then this is later followed by an upward deflection, which is referred to as an R wave. So if there's an upward deflection, regardless of whether there is a Q wave or not, you refer to that as the R wave. Then of course the R wave later follows another downward deflection, which is referred to as the S wave. Now this QRS complex must have a normal morphology and a normal duration. So normally it should be 0.06 to 0.12 seconds. So less than the 3 small squares. If you realize, most of these things are going to be less than 5 squares. So that's the rule of thumb. Most of them are less than 5 squares. So if you are going past 5 squares, then that's a very significant thing. And for you to actually reach 5 squares, it will be very easy for you to notice. So take note of that. And remember that the amplitude of this QRS complex can vary with different scenarios. It can vary with age, it could vary with race, it could vary with different cardiac pathologies, and this QRS complex increases with amplitude as we go from V1 to V5. And this makes sense because as we get to V4 and V5, those are very close to the lateral surface of the left ventricle, and most of the majority of the heart is much closer to the thoracic cavity than with V1 and V2. So remember that this shape of the QRS complex, the rule of thumb is this: if, for example, you are suspecting that there is a problem affecting the heart, if the problem is above the ventricles, usually the QRS complex will have a normal morphology. So it'll be narrow, okay? So you could have maybe a narrow QRS complex arrhythmia. Then if the problem is actually within the ventricles, then the QRS complex usually tends to change its shape. It tends to be bizarre. So it means that if the problem is above the ventricles, the QRS complex is more likely to be normal because the conduction in the ventricles is most likely to be normal. Then if it's affecting the ventricles, the QRS complex will appear bizarre because it's affecting the conduction in the ventricles. Then remember that this shape of the QRS complex is largely dependent on two important things. So remember that the first thing is that the septum that you find in between the ventricles is going to be depolarized before the walls of the ventricles. And this depolarization is going to be spreading in such a way that it spreads across this ventricle from a left to a right direction. Okay, now take note of this, because remember when I told you that the progression of the height of the QRS complex increases from V1 to V5. And remember, V1 is on the right and V5 is on the left, so keep that in mind. Then also the second point is that if you have a normal heart, generally the walls of the left ventricle are much larger than the walls of the right ventricle. So it would mean that the left ventricle is going to be exerting a much greater influence on the QRS complex than the right ventricle is. So it means that the shape of the right ventricle would be determined by the direction of the depolarization, the septum being depolarized first, and then this spread of current sweeping from the left to the right. The second point being that because the left ventricle has a much greater mass than the right ventricle, it would mean that the ECG pattern is more influenced by the left ventricle than it is by the right ventricle. So like I told you, remember leads V1 and V2 are pretty much going to be looking at the right ventricle. Then lead V3 and V4 are pretty much going to be looking at the septum. Then lead V5 and V6 are pretty much going to be looking at the left ventricle. Okay, so keep these principles in mind. So remember that inside the right ventricle, when the right ventricle depolarizes, this is going to be responsible for the first upward deflection, what we call the R wave. Okay, and when this right ventricle depolarizes, especially in leads V1 and V2, you get this R wave. And then when the septum, so it's going to be this depolarization of the right ventricle, or the right ventricular leads are going to have a deflection, because the first thing that's going to depolarize is the septum. Okay, so the septum will depolarize at first, and once the septum has now depolarized, this will cause an upward deflection, an R wave. So it means that in leads V1 and V2, which are involving the right ventricle and the septum, there won't be any Q wave. So there's no Q wave. Then on the other hand, in the left ventricle, the pattern is pretty opposite. So there's usually a small downward deflection, which is known as the septal Q wave. So it means in the left ventricle, so in the other leads V3, V4, V5, you get to see the Q wave, the small Q wave that is there. Then in the right ventricular leads, specifically V1 and V2, there's also going to be, after you have this R wave that has depolarized, there's going to be another depolarization, which is going to be the S wave. That's now due to the muscle of the ventricle actually depolarizing. But remember that the electrical effects are much greater with the left ventricle because it has a larger mass than the right ventricle. And remember that in the left ventricle, the depolarization is going to be spreading from the right ventricular lead. So it's going to be spreading away from V1 and V2, whilst the depolarization current, which tends to be moving towards the right ventricular leads, V1 and V2, is going to be much smaller in V1 and V2 in the right ventricle, which is why in V1 and V2, remember from our previous lecture on the principles, if the current is flowing towards the electrode, it will give you a positive deflection. If it's flowing away from the electrode, it will give you a negative deflection. So in the small right ventricle, because this impulse is flowing towards the electrode, it gives you an upward deflection. That is what is responsible for this R wave. Then in this same V1 and V2, because the impulse is moving away from these leads, the V1 and V2, there won't be any Q wave. Okay, or if there's a Q wave, it's very subtle. So again, in the left ventricular leads, that's V4 and V5, there's V3 and V4, there's pretty much going to be an upward deflection, which is the R wave. This is going to be representing this depolarization of the ventricular muscle. And remember, when the whole myocardium is going to be depolarized, the ECG will eventually return to its baseline. So remember that now this QRS complex in the chest is going to show a progressive increase from V1 to V6. So in leads V1, it will be predominantly downwards. Then as you go towards V6, it becomes an upward deflection. So here's a depiction of the three stages that I've been talking to you about. So in stage 1, where there is that initial depolarization, remember in V1, you get a positive R wave because the impulse is moving towards V1. Then in V6, you get the opposite thing. You get a downward deflection, which is known as the Q wave. So you do not see a Q wave in leads V1, but you see the Q wave in lead V6. Then in the second phase, you get a downward deflection in this lead V1, whilst you get an upward deflection here of the R wave. Remember, here you only have an RS wave, no Q wave, but here you have a Q, R, and S wave, which is what's happening in the third stage here, where you have this returning to baseline here, where you have your RS wave, and then you have your Q, R, and eventually the S wave there, returning it to or the R wave, returning it to baseline. Okay, so it means that progressively, as you move from leads V1 to V6, the amplitude of this R wave, as we can see, the R wave progressively increases and becomes more positive, whilst the amplitude of the S wave progressively decreases. So this progression This is how it should normally look like on the ECG. It's referred to as the RS progression. Now, even when you're interpreting your ECG, if you get a poor RS progression, that's going to denote certain pathologies on your ECG. So please take note of this. Then the other segment that's here on the ECG is known as the ST segment. So this is just pretty much the time it takes between ventricular depolarization and ventricular repolarization. So it's at the end of the QRS complex to the beginning of the T wave. Some people may even consider another segment which is known as the TP segment, which is at the end of the T wave to the beginning of the P wave. But one important thing that you need to know is this ST segment, it is at an isoelectric line or an isoelectric point. So it should neither be positive nor should it be negative. If it's positive, you call that as ST segment elevation, which will obviously signify one of the most important things is that there could be a myocardial infarction, what is known as an ST segment myocardial infarction, which is known as a STEMI. Or if this ST segment is depressed, you can call that as an NSTEMI, the non-ST segment elevation myocardial infarction. And the point where this QRS complex actually meets the beginning of the ST segment, you refer to that as the J point. So I presume J is for junction point or joining point. So this J point sometimes could be elevated and form a wave, which is known as an Osborn wave. So if you get an Osborn wave, this is simply just going to be showing you that there is a distortion in the early phase of the membrane repolarization. Okay? And this is very, very common in patients that have hypothermia. So you get these Osborn waves in patients with hypothermia. Then the last or second last in some patients, because you may also get a U wave, you will get to see a T wave. So these T waves are usually upright as well. So they are upright in all the leads except leads AVR, where it's inverted, lead AVL, lead 3, and lead V1. Then these T waves are going to be representing ventricular repolarization, but you may get some T wave invasion in leads V1, V2, V3, and V4, especially in children. That's a normal thing. So that's why I said in the previous lecture that please marry the history with what you see on physical examination with what you see on your ECG. So you get a normal child, then you take an ECG and you realize that this inversion of the T waves, that's pretty much normal in leads V1 to V4. Then of course in adults you may get T wave inversion, but it's less common, and if you find it, it's usually found in V1 and V2 as well as V3. And remember that the depth of the T wave also progressively becomes shallow as you go from one lead to another. But the rule of thumb is this: if you're looking at the limb leads, pretty much lead 1, lead 2, lead 3, AVL, AVR, and AVL, the T wave should not be greater than 5 small boxes. Like I told you, most of these waves are not greater than 5 small boxes. Then with the chest leads, that's a precordial leads, V1 up to V6, the T wave should not be greater than 10 small boxes. So if it's greater than 10 small boxes, then that's you call that as a peaked T wave, which could signify things like hyperkalemia. Then sometimes you may get a U wave. So this is pretty much a small rounded upright wave that usually follows the T wave. So it's seen especially when the heart rate is very slow. So if the heart rate is much faster, then you won't able to recognize this U wave. And what this U wave pretty much represents is repolarization of the Purkinje fibers. Then you also have a QT interval, which is usually measured from the beginning of the QRS complex to the end of the T wave. So this is simply showing you ventricular activity, so meaning ventricular depolarization and ventricular repolarization. Some drugs can cause prolongation of the QT interval and can predispose someone to having ventricular arrhythmias, even one of the feared arrhythmias, which is known as the torsade de points, which is a French word meaning twisting points. Then you may also get sudden cardiac death. Then of course some medications do cause prolongation of the QT interval. So remember that once a QT interval prolongs, if you have a fast QT interval, you are going to be having a fast heart rate. So if you have a slow heart rate, you're going to be having a prolonged QT interval or a long QT interval. Now, because your heartbeat varies from time to time. Sometimes it speeds up a bit, sometimes it slows down. We're not machines. We don't keep it constant at 75 beats per minute for the entire minute. No, that's like an average. So there's a variation. Because of this variation, you can find what is known as a corrected QT interval. So the corrected QT interval, actually the ECG machine corrects for this variation in the heart rate, and you can actually calculate what is known as the corrected QT interval B, which is pretty much the QT interval divided by the square root of the RR interval, which is the distance from one R wave to another R wave. And then this formula is known as the Bazet's formula. And this normal interval is in men is usually less than 0.44 seconds, or in females is usually less than 0.46 seconds. So if this is prolonged, it means that you have a very long QT interval. Thank you for taking your time to listen to this lecture video on the different waveforms of the ECG pattern. Now in our next lecture, please stay tuned, because we are now going to start in the systematic approach of how we should read an ECG. Until next time, my name is Dr. Moses Kazevu. Bye-bye.